Think we'll give about 1 or 2 more minutes for others to join and then we'll get started. Wonderful. Hello. We'll go ahead and get started. It's right at 9 o'clock. I am really excited that we could put together this conversation today. Um, we'll get started with our co-hosts and speakers in just a second, but I just want to speak to all of our participants and guests that are joining us today. Feel free to use the chat box. Feel free to use the question and answer or Q&A that you see at the bottom. Also want everyone to know that we are live streaming on YouTube. So that's also happening. Let's see, let's make sure we're also recording. Okay. So I'm very excited today to bring together two of my friends and colleagues, Dr. Wesley Rajalilan and Dr. Holgar Moi. Moi, is that how you say it? Moi?
That's right. That's correct.
Perfect. Um, we often talk a lot as friends about global health, about health systems, about workforce training, and these are all conversations that we have often just as friends and colleagues. So I wanted to kind of bring this conversation and these important topics really to a larger audience. So that's why we've decided to do this webinar today. So we called it Cameroon to Canada, the changing landscape of global health, and that landscape certainly has changed. Um, so today I kind of want to talk about workforce migration or professional mobility, some of the geopolitics, equity, and the growing global interdependence that we have. Rather than doing the typical flow with me introducing you and doing a bio sketch, I want each of us just to spend a second answering a few questions to let the audience get to know each one of us. So I'll start with you, Dr. Wesley, if you don't mind. Where did you grow up? Where did you train? And where do you practice now?
Uh, Thank you, so much, Dr. Crawford, for the invite. Absolutely stoked to be here. So, I'm originally from the southern part of India. I was born and raised there. Did my med school and training there. For a brief stint in UK, I moved to Canada for my advanced training fellowships in regional and obstetrics. Now I teach and practice and work in a tertiary university teaching hospital in the capital of the country. Ottawa is the capital of the country. It's not Toronto, by the way. So I work at the University of Ottawa. I practice regional high-risk obstetrics, a bit of high-risk obstetrics, and I'm also the director for global health for the University of Ottawa within the Department of Anesthesiology. Um, and yeah, that's about myself.
I love your plug for Ottawa because I think Toronto is such a big city that
Yeah.
they probably think they're the capital, isn't it?
Oh yeah, absolutely.
Wonderful. Dr. Holgar, tell us more about you.
Thank you, Dr. Crawford, for putting this together. Like my name is Holger Moa. I'm a Cameroonian, born and raised. I was born here, obtained my primary medical degree here in Cameroon, then moved overseas for specialist training in Israel, where I trained in anesthesia and critical care. and then later did a fellowship and then worked in Israel before I moved back to Cameroon. So currently I work at the Centre des Urgences Yaoundé, which is like a first level trauma center in the capital city of the country.
Great. I am Anna Crawford. I do anesthesia and critical care. I was born in Southern California in a town called Fullerton, and I grew up going back and forth between California and Alabama, which, if anyone is familiar with the United States, those are two very different places. So I feel like my cultural awareness was expanded very early in my life. I trained all in the United States. I did anesthesia and critical care in at Parkland Hospital or UT Southwestern in Dallas. And then I came to Stanford University as a fellow and I did my fellowship in critical care medicine. And then I went on to get a master's degree in global health sciences from the University of California at San Francisco, so UCSF. Um, what I'm going to start with you guys again and ask you what motivates you the most to engage in global health? And this time I'll get Holger to go first.
That's a very interesting question. I think my motivation comes from my early experiences working as a GP, where I realized early on that in my context, triage sometimes the question we ask is not what is the diagnosis, is can the patient afford the next step of in the care pathway? So, I mean, early on, I was able to understand that, I mean, financial barriers, it's a huge obstacle for patients to access care, which obviously impacts on outcomes. So, I mean, there on, I said, okay, this is something I want to be doing. I want to understand how systems work to protect the most vulnerable members of our society. And that's how I got involved in global health.
That's great. I mean, I think that's a common thread amongst all of us is really trying to advocate for those patients really that don't have as much. How about you, Dr. Wesley?
Um, so right from the start, I've always been interested in working in places of need. So before the concept of global health, I was more of a humanitarian aid worker. I've been with the MSF for the last decade. So what had changed was over past 10 years with MSF. It's not about you going to a place of need, do your work and getting out, and then what happens? Everything falls back in the same place. So. Um, Something changed in me the first 2 years with MSF that we need to make whatever programs you're part of or supporting should be more sustainable, and we brought in the concept of teaching and making healthcare accessible to to the populace who are there even after you leave. So that's when I started exploring more about health equity and global health and strengthening and sustainability programs, and then one led to the other, and here I am.
Many years later, right? How long have you been practicing or engaging in what you would consider global health, Dr. Wesley?
I'd say a little, almost a decade, almost like 8 to 9 years now. Yeah.
Okay. How about you, Holger?
I'll say more. I mean, right out of med school, I was engaged in global health. Like that was like 13 years ago.
Yeah, yeah. I feel like
Yeah.
my stories started similarly as far as motivation, but obviously in different contexts, being from the United States. My first exposure was really in my late 20s, early 30s when I was like an intern. So this is even prior to anesthesia training, and I had the opportunity to travel to Kenya. And I hadn't even left my own country before. This was really one of my first trips. So definitely eye-opening. But I think like a lot of people, I started out with a trip that would be considered a mission trip or a service provision trip. And at the end of the trip, all of the people that I was with really thought that we did such a great job and we'd seen so many patients, but I left with the impression that we didn't do much at all because we hadn't changed the system, and so we didn't have a lasting impact or maintain those relationships or help to build that system. And so I think that's when I really started thinking about health systems and all the different things that it takes to really make an impact for communities. Um, I want to take us a little bit down a road that I think Dr. Wesley might have started when he said global health, and he put it in quotations. So I kind of know why you put it in quotations, but I want to ask both of you, what do you see as the definition of global health? I was actually asked this question yesterday. What do you think is the definition of global health, and is it a static definition? Maybe start with you, Dr. Wesley, since you brought in the quotation, the finger quotes.
So, no specific reason about the finger quotes, because whenever I mean, it's not many people understand what global health is all about. People think, I mean, a lot of my friends think it's more of something I do on the side as a hobby, or not like, I mean, something I do in my free time. It's not essentially that. To me, global health is for me primarily baseline. It means health equity, right? So sustainable health equity. So what I the kind of health coverage I enjoy in a so-called HIC like Canada should be should be the same throughout all throughout the globe, all throughout even Canada for that matter, from north to south, east to west, accessible to healthcare, health equity, health economics. Uh, is one of the main distinctions, or is how I would personally define global health, is health equity for all.
Mm. Anything you want to add to that, Dr. Holger?
Yeah, sure. I think for me, in addition to what Dr. West has said, I think the world has become a global village where we share similar threats, and we have to like collaborate in order to combat these threats, and that's where global health really has a place. Um, like, I mean, for example, if 2019 reminds us all on how we had collective effort in combating a common enemy, the COVID-19, and so I think global health, sometimes people like to, like Dr. West said, people like to see it as a hobby, or maybe a second job where, okay, I can spend 2 hours a day just doing it. But I mean, it's a discipline in and of itself in trying to understand how health systems interact with each other between high and low income countries, and how we can bridge the gap in making sure that the most vulnerable members of society, that their needs are met in order for everyone to live a healthy and happy life. I think for me, essentially, that's what global health entails.
Can we talk about some of the language that we use? When we say high income country or low and middle income country, do you think that this terminology is too blunt, or do you think it's an accurate way to describe disparities? So I guess what I mean is, even Dr. Wesley, you just mentioned a minute ago that even within Canada, which would fall under high income country according to these World Bank designations, has disparities within the country as well. So I think a lot about this, and almost every time I type high income country or low and middle income country, I just think it may not be the best way for us to describe what the patients are experiencing, because I think you may have heard this, but in the United States, we sometimes say you can receive the best medical care available in the world, but also the worst medical care available in the world. So can you tell me a little bit about your thoughts around some of the language that we use and some of the nuance that might or might not be missing, when we use those terms, I think.
Uh, for me personally, I don't like to silo high income countries and low income countries only based on monetary. I mean, uh, i- income, like money, okay, monetary is important, but I think I guess it's just a part of overall when you classify these countries, right? It should be more holistic in terms of cultural backgrounds. Like, when most of to be like when you go back in history, like when we go back, say, thousands of years, by which time when man was learning how to make fire and wheels, a lot of civilizations was happening in Africa and the Middle East, where the cradle of civilization. So I don't classically like to call high income countries low and middle income countries only based on monetary backgrounds, but it also should be a lot more cultural backgrounds, ethnic backgrounds, or uh, a lot more to just monetary benefit. Like, even I recently came to know about this term called sub-Saharan Africa, when people over the terms use the term sub-Saharan Africa. It was actually, when I look back on the history of how that term coined, it was mainly based on the high income countries of Africa kind of said, okay, we are on top, the top tier nations, and then the rest of Africa is, only based on money, only based on economy and money. So there's a lot of historical backgrounds we need to actually, look into when we silo these terms such as HICs and LMICs and low LICs. So I
Yeah.
think it's more than monetary. I think we should actually get into the bottom of it, look at the historical background of why we use this term. Is it right? Is it is because when we do this work, when I engage with a lot of my partners, I've been around, I've traveled. It teaches a lot of cultural sensitivity, and when you have that, in you, you kind of don't silo these into LMICs or HICs or LICs. It's my very personal opinion.
Yeah, I mean, Dr. Wesley, you could, I mean, I couldn't agree more with you. I wanted to share this terminology from a patient perspective, right? For example, I think patients have different experiences based on geography, but I believe that deep down, they want a similar outcome. Like, they want to get better, they want to go home and all those things. So the divide of high income country, low income country based on GDP alone, I don't think it's a true metric in categorizing healthcare systems. I think it should be a term solely used by economists, and I think that term has no place in healthcare. I really believe the term shouldn't be used in healthcare.
Yeah.
Because in healthcare, we want to create an environment where people can actually, I mean, have access to care, get the best quality care, and then go home with better outcomes. And that entails putting structures in place and the processes of care that would lead to these outcomes. So I really think all healthcare systems around the world, they share these commonalities in terms of structures and processes of care, but the outcomes might be different based on the different experiences. And I think what global health should try to do is not borrow the economic term of high income countries. They have more resources against low income countries. They have low resources in trying to create that divide. I think we should just strive towards creating a system where everybody can benefit from the same infrastructure, from the same processes of care to have the same outcomes.
Yeah, I obviously agree with both of you, and a couple of the things I think that you've already mentioned. It really has to do with systems, right? So we keep coming back to these systems, and whether or not these systems are able to deliver the care that patients need from both an access and a quality perspective. Um, and actually, there's already a question in the Q&A about the interchangeable terms public health and global health, and what's the difference. And I think it's kind of been an evolution of language, and it's changed a lot. And I think this is part of the global health definition and how it changes over time. But so it's a little bit hard sometimes not to create these broad frameworks, especially when we're writing and working on advocacy and things like that. But do you have a terminology that you prefer over HIC, LMIC versus this yeah, economic or monetary description of disparity really is what we're talking about?
So you want
I
to go
think,
first? Yeah. Yeah.
yeah, sure. I mean, for me, what I've consistently used when in my academic work is I mean, resource limited settings. That's something that I mean we can identify with. For example, if you're comparing a healthcare system in Cameroon, for example, with that of the United States, I mean, you're limited by infrastructure in performing certain types of surgeries, right? And that would entail, okay, the system is limited by resources, not necessarily because it's a low income country. Because I mean, where do you put governance in all of this? You could have all the resources you want, but if you don't have good governance, I mean, you still have low resources. So I really think the term of in I think in healthcare or in global health, we can talk of low resource settings and fully resourced settings. I think that's a term that adequately captures when you're describing the disparities in
Mhm.
healthcare systems in the world, rather than high income and low income.
Uh, for me personally, I would probably, I don't know the right answer, but I would probably classify to how the healthcare of that particular place is funded. Like not funded, I would say. Like Canada has a public health system. In India, it's both public and private. But if you have the money, you get the best healthcare, one of the best healthcares in the world. If you don't, you go to the public health system, which is good in some places, which is not so good in some places. Correct. I would probably silo it in as public funded or private funded because uh, it's more of uh, it's more of not siloing it according to the economy of that particular place rather than how the health systems function or how health systems are. I know it eventually bogs down to money, but I guess it shouldn't be based on the economy or the GDP of that particular country, but rather than how the health system is framed or funded.
Yeah, yeah. I think about high resource, low resource, resource constrained, variably resourced. And I have to confess, I've used all of these things, including LMIC, HIC, in my writing because none of them, frankly, are really good descriptions of what we're trying to get at. So we and it really does occur along a spectrum, right? There's a hospital in one place and 5 minutes down the road there's another hospital that's completely lacking some of the basic resources. I also think that we lump countries together, and I think that's a little bit like, we say like the United States is this way, Cameroon is this way, Canada is this way. But that's also a disservice to individual patients and individual communities because um, I think people are often shocked when they come to the United States because it's a wealthy country with basically all the resources that you could ever want. But that doesn't mean that every patient has access to those resources. And so there's very large disparities in individuals or communities' income and access to healthcare. And therefore, the outcomes are really, really different. So you probably know the United States spends more money on healthcare than any other high income country, but our mortality rates, specifically like maternal mortality, infant mortality, or even our life expectancy is not nearly as good as other high income countries. But even within that, there's more nuance because if you look at, for example, cardiovascular care, cancer care, luckily perioperative care around surgery and anesthesia, the United States does really, really well. So I think I don't know that I don't have a right answer either, but I feel like it's really important for us to think about the language that we use when we talk about systems and healthcare. Um, what do you think is if you do have to lump it into a system and a country, what do you think is the biggest challenge, Dr. Holgar, for your patients? And we'll stick to perioperative care since we're all anesthesiologists. What do you think is the biggest barrier to having that access and quality to perioperative care in Cameroon?
Money, money, money. It
Mm,
always boils down to money.
then it goes back to money. Yeah, yeah.
Yeah, I mean, so in Cameroon, the state spends only 3.8% of GDP on healthcare, which means essentially all of the healthcare is borne by the household, approximately 70%. Despite African governments pledging to invest 15% of their respective GDPs into healthcare. So I mean, we're far from from the ideal. Um, I really think the biggest barrier in Cameroon is the financial barrier, because sometimes patients come to the hospital, and like I said in my introduction, the question is not what is the diagnosis or how am I going to treat this patient. I mean, you have to, like, financial consent becomes a constant. It becomes a clinical decision.
Hmm.
Like, do you have money to pay for this?
Hmm.
Right? It's very depressing sometimes, but I really think now the story is changing in Cameroon because there's been an introduction of the universal health coverage.
Hmm.
Although it's still in its infancy, but I'm very hopeful that in the years to come, I mean, that financial barrier won't exist anymore. We'll be dealing with different challenges in terms of increasing access to healthcare, and also reducing disparities in healthcare access. Um, yeah, I think in Cameroon, the out-of-pocket payment, it's a huge barrier, not only for patients, I mean for clinicians as well. Because when you show up, you see, so you know someone is poor. How do you ask them to do a CAT scan, for example? Or how do you ask them to do extensive perioperative
Or
workup?
buy their anesthesia medications or the syringes
It,
or the gloves or everything else. I think this is a little bit of a blind spot for most Americans, but the patients are come to surgery with all of the things that they need for anesthesia.
yeah,
It's mind
yeah.
blowing. Yeah, yeah.
I mean, there's a story I can share a quick story if you let me. So the other day we had a parturian, 14 weeks pregnant. For She had a road traffic accident, and she needed a wound debridement and a lower limb, and we had to do a spinal. So what we do here is that we do a kit specific, like a procedure specific kit prescription,
Hmm.
right? So which means she only paid for a spinal anesthetic without general anesthesia. And then we
Right.
went in, and so the spinal failed despite 2 attempts. Now
Yeah.
we are in the OR, and we have to write a different prescription, like, okay, and call the family. You have to go buy this because we have to convert from regional anesthesia to. So those are just all some of the financial barriers that we
Mhm.
face. Otherwise, if we had a system in place where a patient can afford, like, a comprehensive kit system, where we know, okay, we do know some spinals do fail. Okay, if it does fail, we don't have to call the family in to
Hmm.
go buy all the supplies or drugs for us to convert. I mean, we can just do that right away, like it happened when I was trading in Israel. So, I mean, those are some of the dilemmas that we face, and
Yeah.
you just have to deal with it. You go home, some days you're happy, some days you're just morally broken because you really can't fix the system. What can you do?
Yeah.
But I mean, yeah,
I think it's interesting because we started out with money as that's not a great description of what's happening, but it always comes back to money, frankly. I feel like we could have a whole webinar on this topic, frankly. It's just there's so many things because we talk about the money aspect of that, and that's maybe the missing piece that to which we assign that situation, but it's actually also a governance thing, right? Because if you have universal health coverage, patients should be able to get what they need. I think for all the criticisms that I might come up with for the US healthcare system, one of the things that we have that I think is really great is an EMTALA rule, which basically means if a patient presents for emergency care, they get emergency care, no questions asked. So I think that is one strength of that. So we don't take the whole webinar talking about this topic. In particular, I want to ask both of you who have traveled the world and worked in many different places. What are your thoughts about the concept of brain drain? Because I've actually gotten into very how will I say it? Serious conversations with people about whether it's good or not good for the overall care of communities to have physicians move from one place to the other. And maybe I shouldn't bring my colleagues to Stanford on rotation to have them, see our system and note the differences and teach us about things. So what do you guys think about the concept of brain drain? Are you for it? Are you against it? And why?
Do I
Do you
go
want me to
first?
go for? Oh, yeah,
Yeah, you
please,
go
please.
first. Let's go from India to Canada first, and then we'll get Dr. Moa.
All right. Yeah, absolutely. Brain drain is is the real thing. I guess brain drain occurs when there's movement or extraction without any reciprocity. Like classically high income countries aggressively, like especially the Middle East, aggressively recruit from health systems, like where they know which is functional, and they know they are functioning at a higher level than their own system, so they kind of recruit quite aggressively.
Yeah,
They invest in
I get those emails all the time. Yeah.
yeah. And they kind of invest in training, and because they want to gain capacity, and then when there's no bilateral agreement or any compensation involved, and because when someone moves from one place to the other, there's no mutual beneficence to that particular person. Because I personally believe that true exchanges can exist only when there are structured pathways which is available, like bilateral training partnerships that we have with various universities. When they lack capacity building, that kind of strengthens their own health systems rather than substituting it. Is that the right word? Yeah, substituting it for it. And the lack of like researchers, the lack of research funding, or leadership within researchers, because a lot of researchers move to the so-called HICs only because of research funding. And of course, now it's all up in the air now. The laws of a lot of funding,
Yeah,
right, from the
we can
United
definitely talk
States
about
now.
that too.
Yeah.
The funding mechanisms have
Yeah.
changed
So
a
yeah,
lot.
to me, yeah, to be of what would look like utopia, like in the utopian concept of what would be ideal would be where there are reciprocal accreditation pathways where they can have bilateral mobility, which would eventually help both sides. Bilateral workforce planning, when two countries where they can align recruitment, rather than moving totally shifting from one side or the other. And of course, funded exchange programs would be the best way forward. And when people come back, protected salaries, leadership positions, mentorship, which is a structured mentorship is what I mean, and return incentives would probably take care of the brain drain. Is my very humble personal opinion.
Yeah. The ACGME, or Accreditation Council for Graduate Medical Education, is a certifying council essentially in the United States for all of our residency training programs and fellowship training programs. They've actually launched ACGME Global, and they're trying to address what you just outlined, which is making sure that there's maybe like a standard set of things that are accomplished by training programs, so that people can move between these settings more easily without having to resit exams or actually go all the way back through a residency training program, which is the fact in the United States. And I'll just say that quickly, and then I definitely want to hear from Holger because I know he's got a lot to say about this. I think when I get into these, I don't want to call them arguments, but heated discussions about brain drain, I feel like it is a concept of equity and justice, in that I trained in the United States, and I can very easily go work in a lot of other countries with very minimal effort. I don't have to reset exams, or, well, sometimes I have to reset exams, but there are countries that I can go to without resetting exams. So I think it's more about, why should one professional physician in one country be able to have that professional mobility when others cannot? And I think kind of goes back a little bit, Dr. Wesley, about, how do we make sure that each training program accomplishes the same thing? Dr. Holger, you are going through it. You have been to multiple countries, and I also know a little bit about your future plans. So, do you want to talk about brain drain and professional mobility from your perspective?
Uh, sure. So I would
Thank you.
like to build on I would like to build on what you have said, which I completely agree on. But I would like to pivot on and another component of brain drain, which is brain circulation. And the best way for me to convey that information is by
I love this
providing you,
description, by the way. I love this description.
yeah, by providing like practical examples of things that we've lived here in Cameroon, myself, and even, I mean, as a system-wide initiative. So we had, I mean, I've personally known physicians who had to leave the country because they felt capped, like their capacity had surpassed the resources that they had in order for them to practice, and they had to leave the country. And when they left the country, they really never left because they came back and they're giving back to the country in ways that are way more than if they had stayed. So I want to highlight two platforms here, no publicity. I mean, there's the Global Health Otherwise platform run by a prolific Cameroonian who is giving back to the community in ways that, I mean, through mentorship, structured career coaching, and also advocacy. And there's the Cameroon Town Hall for the Cameroon Town Hall for healthcare professionals, which has connected more than 2,000 healthcare professionals from Cameroon around the world who have contributed their expertise in one way or the other to building the nation or the Ministry of Health. And that effort has led to the ministry creating a department into the department that is in charge of the diaspora. So, for example, if you work in the diaspora and you want to contribute to the country, you just simply go through that ministry, and they facilitate your way in giving back to the country. I think that's something huge, and is a very positive thing that I
It's
have
brilliant.
personally experienced. And so I am, and speaking about myself, I was trained abroad, but I came back to work in Cameroon, and I think the community is benefiting from the training I received overseas. So I really think I don't want to see it as brain drain as very bad. I mean, brain drain becomes a problem when it's unidirectional. But still, we have to put into context why people leave in the first place, because migration is never a very simple decision. You have the pull and push factors that can range from economics to finances to, I mean, safety, like wars. I mean, wars can make people to move.
Yeah.
They want to move, but they
Wellness
want to contribute that. Yeah.
and burnout.
So, I mean, I am for brain drain. I really don't like the term a lot because I've only had positive experiences with people who left the country that were considered they were considered as if they left the country, like the country had lost potential, but what they have given back to the country is way more than if they had stayed in the country. So I am for it, so long as it's a bidirectional, it goes in both ways, where there's a component of giving back.
If we are going to
Uh,
have an honest debate about brain drain, we would have to play to the other side, which is brain drain is bad. Some of the programs that I love the most that I'm involved with bring my friends and colleagues from other countries to the United States. So we have a program here at Stanford that I created that brings colleagues to rotate at Stanford. And then Holgar, you and I met through the ASA Global Scholars Program, and have been friends since. So I love these programs, but I do have to say, and then Dr. Wesley, you in Canada, you have the Canadian Anesthesiologist Society International Education Foundation, which also have hosts programs and hosts international colleagues to come to Canada. And just to play devil's advocate, I have to say we have, not in the majority, definitely a small percentage, we have had people come to Canada or the US and disappear and not go back to their country and break communication with their host programs. So that's very upsetting because I think this may actually be the true definition of brain drain, in that I know in the US they're not practicing physicians and they're not using their skill set because it's virtually impossible to do so in the US from another country. But I don't know, Dr. Wesley, I know you've heard about this and or experienced it personally where you have lost some of your friends.
As we speak.
Yeah. Oh, really?
Yeah,
Right now?
oh,
Oh,
yeah.
yeah.
As we speak, yeah, of course, a blade always has two sides to it. So but I think, as you said, it's a very small minority. It's a very small minority. It's not the major chunk of it. But we do face these situations very often. Not so often, but of course they do arise. I
We
really
think
don't.
about it often. We think about it
Oh
often
yeah, yeah,
and
of course,
wondering if we're doing the
absolutely,
right thing. Yeah.
absolutely, absolutely. But I don't know. I mean, I don't have an answer to it because, as Holga said, there are a lot of reasons why people do it. There's a lot of influences, as you said, instability, war, financial reasons, or whatever it may be. But I honestly don't have an answer to it. How do I face it? I honestly don't have an answer to it.
Yeah. I think if we were going to approach it like scientists, we could do some quantitative and qualitative analysis. And I think quantitatively, we've had more good things come out of these partnerships and collaborations
Absolutely.
across countries and development of leadership and professional development, as well as education programs, as well as actual clinical service. So I think that would be our quantitative that we could look at. And from a qualitative standpoint, I would just say that having friends like you, and I see so many of my friends in the participant list, it's one of the best things that I've ever experienced in my life, and I feel very, very grateful to have friends all over the world that help me evolve as a clinician and as a global health person. So qualitatively, I'm very much so for international collaboration and global engagement.
And for me personally, as a person, as a human, I mean, I've learned so much from
Mhm.
what I take in.
Yeah, yeah. Dr. Holgar, you met a lot of people through your ASA Global Scholars program. How do you feel that cohort interacts with each other, or what did you learn or contribute to that cohort? Because that was a group of people that came to the US together from many different countries. Did you see any unique value in that experience?
It was how can I say it? Sometimes I like words to characterize the what I gained out of it and how I'm planning to contribute to it in the future. I think meeting people from different backgrounds, you get to hear their stories and you learn, and it's a rekindling moment because you get to see what you things that you might take for granted in your context, you get to experience those things through other people. For example, we like I still keep in touch with almost everybody. Like we have a forum where we chat every week, just to keep up with each other's what endeavors, whatever what they're doing. And specifically with my colleague from Ghana, Theresa, I think we are planning a collaborative research on maternal health in the upcoming months, which I mean, it's an initiative that couldn't have been born if I didn't meet her in this experience.
Yeah.
And I continue to receive mentorship from you, from Dr. Batnick, and who keeps sharing links for, I mean, all these opportunities to advance knowledge in pain and also not only pain in anesthesia and critical care. I think it was a very rewarding experience for me. If I had to do it again, I mean, without hesitation, I would do it, and I'm
I would,
advocating for
I would,
action.
I would have you again. I would have you come as much as you wanted if I had all the control. I will make a quick plug for Dr. Wesley and myself. At the beginning of the year, if you're on LinkedIn determined that the person that Dr. Wesley interacted with the most on LinkedIn was me, and I think he was in my top 5 as well. And I think one thing that and I'm not going to speak for you, I want to hear your opinion too, but one of the things that we like about LinkedIn is it is dedicated to professional people, and it's not like other
Absolutely.
social media platforms where there's a bunch of noise. But one of my goals on LinkedIn is to share any and every opportunity that I see. So I'm constantly reposting opportunities for further study, opportunities for jobs, opportunities to join webinars, opportunities to present, conferences, etc. Um, and I think that's been pretty fun because you meet again more friends around the world, but also I think it's quite useful. What do you think, Dr. Wesley?
Oh,
I know.
absolutely. I agree 100%. I
I
mean,
am not getting
the
paid by LinkedIn, by the way.
no, the contacts you get, and it's like, even like with the Ottawa our partnership initiatives, uh, like with a lot of LinkedIn's. Actually, we have some like we a huge company came forward, looked at our work, and they now they kind of fund. planning to fund, at least I would say, a large chunk of our outreach work we do in Tanzania, and it's all because of LinkedIn, because we talk about it. We even within the leadership, because at the perioperative services, they kind of see the value in what we do, and I think all this is possible only when we talk about it, and when it goes on a public forum like LinkedIn, and they see the work we do, they'll do their own research, and I guess it's absolutely beneficial.
Yeah. Okay, before we leave the topic of professional mobility, I want to get
Hi,
both.
Anna, can I just
Oh,
interject,
yes, of course.
please?
Please. Of course.
Yeah, I mean, Dr. Wesley, and I mean, it's an appeal to you. Please send some of those projects to Cameroon. I mean, you've been to the
Oh,
East so many times. We do
100%.
speak English in Cameroon as well. Please
No, it's
come
a,
to Cameroon. You're welcome to Cameroon. Yeah,
I've
we
been to
need you
Yolande,
here.
by the way.
Yeah,
I've
we
been to
need you
Cameroon.
here.
Yeah,
Yeah, okay,
absolutely.
perfect. So we need you
Um,
here, please.
you're so fun. Okay. Now I've forgotten what I was going to say. Oh, before we leave professional mobility, I want to ask you guys about brain drain within countries. So we talked about the Middle East is trying to get me to move there, and we're trying to get Holgar to move to the United States and things like that. But it really does happen within countries as well. I've noticed that like as capacity expands in one country in East Africa, it's pulling from other countries in East Africa. Do you have experience with that, Holgar?
Yes, we do.
Mhm.
And one of the I think the push factor is conflict.
Mhm.
So we have we have two conflict affected regions in the country at the moment, and clinicians really don't want to practice there because of all the insecurity that prevails. So they rather tend to move to the cities or to other regions where they they feel safe, and this creates an equity problem because I mean the populations that are trapped behind, how do they get? I mean, even if they can access care, they don't have
Mhm.
providers who can care for them. So it's a serious problem here, and but thankfully the government is trying to resolve those issues and try to and security is gradually returning back to normal.
Mhm.
And we hope that once things get back to normal, people can move back to these regions and care for patients.
Yeah.
Other factors also are just in terms of the infrastructure. People want to be where their children can go to school and have meaningful social connections and opportunities. So, I mean, nobody wants to work in a rural area where you don't have decent schools for your children
Well,
or playgrounds or,
infrastructure and the infrastructure to provide the care that patients need, right? So
yeah,
we have a very similar um, migration of healthcare workers from the rural settings to the urban settings because there's a lot more available. So you have the schools, you may get paid more, and also you have the tools to take care of patients in a better way.
yeah, yeah. I think we share those realities as well in Cameroon.
Yeah. There's another interesting migration pattern in the United States, I think that I already talked about, right? That Americans are leaving the United States in record numbers because it's so expensive here. So a lot of people are looking, I think probably more in the retirement age group, but even across working adults, like people are looking for cheaper places to live. So I think that's an interesting trend. I think conflict, as you talked about, Holger, is something really exceptional, exceptionally challenging. That is hard for other people, to really help address. But yeah, I would probably be gone too if I was scared. Dr. Wesley, do you have any thoughts about that topic?
Oh, 100%, absolutely. Like Canada's healthcare system, like if you go up north to the territories, Northwest Territories or Yukon, or even Iqaluit, I mean, I've been around, and I know the complexities of the healthcare systems around. I mean, there's so much disparity even within the country. I mean, we have the second best hospital, like the Toronto General, and then we have hospitals up in the territories which are uh, I which really lack in systemic structures which would help them to work as a hospital. So there's a huge disparity within the country as well, and that's why a lot of the government is trying to pull in a lot of alternative funding packages for to encourage physicians to work in rural areas, like we're looking
Even
at.
Americans, maybe Canada's poaching on America.
Oh, the number of American applicants now, oh, yeah, of course, and we are trying to look at alternative anesthetic, we are bringing in the concept of team-based approaches or task sharing, as I mentioned, empowering anesthesia assistants with the help of supervision in these spaces. So there's a lot of work which is being done, and like rural intense incentives and remote and virtual care. There's a lot of work being done, and it's within the country itself.
That's a perfect segue to another topic I definitely wanted to bring forward with the two of you because I admire both of you so much and consider you thought leaders
Likewise.
in the space of global health for sure. But you mentioned task sharing, which made me think of the cognitive and administrative burden that is placed on clinicians. And then you also mentioned something about telemedicine. So, what do you both think about artificial intelligence and global health? And I'm going to leave that question super broad to give you a lot of space to move around and think and share some of the thoughts that you have about artificial intelligence and global health. Maybe Dr.
Uh,
Olgar, you could start maybe on this one.
Yeah, sure. I mean, this is a very interesting topic because when large language models first came out, I think it was 2023, 2022, late 2022, 2023. I think I was still in Israel, and in my hospital at the time, there was research ongoing on how to predict hemodynamic instability in patients using large language models. And it was very strange to me at the time, like, because I didn't know what a large language model was or what it was. And then when I read a little bit into it, I was like, oh, so you're using data to actually understand patterns to predict so that you can predict if a patient has intraoperative hypertension or not. And it was very enriching. And then moving back to Cameroon, I was in very close proximity with AI, working in global health, in the global health space. I mean, far from anesthesia. That was in chronic kidney disease. So the ministry commissioned a project to screen 34,000 lives for chronic kidney disease markers, albuminuria and urine creatinine and blood urea nitrogen. And it was amazing. And it was very, very satisfying to me to see how AI was able to help us achieve those results in record time. In 4 months, we were able to reach 34,000 people
Right.
using point of care and predictive analytics from AI, which is something I had never seen and never experienced. I was so pleased to be part of it. And what I learned from that experience is that AI can truly decentralize access to care by providing results in real time that inform clinical decisions that can lead to timely care.
Mm-hmm.
Because we were able to go into remote communities where, they had never seen a specialist. And with just basic point of care tools and AI, we were able to know their kidney health and refer them timely to see a nephrologist in another city. Something that could have never happened if we didn't have this AI.
Yeah.
I
Doc-
mean,
oh,
after,
sorry.
yeah, no, please go ahead.
I was just going to ask Dr. Wesley, I think I think everybody knows that AI stands for artificial intelligence, although Holgar just made a good argument that it might be Accelerator International or something like that, because it really does make things happen really, really quickly. Maybe you could tell us a little bit about the different ways AI can be used. I'm not sure how much you know
yeah,
about AI, but
right.
because I think some people still don't really know what it is, and we
Oh
talk about
yeah,
large language models, but that's really just
yeah,
one type of
yeah.
AI and things like that.
So,
How much do you think about this stuff?
I just wished wish my friend, a colleague of mine, or no, he's another Cameroonian. He works with me here. I wish he
Small
does
world.
big research on AI. He works with me, but for what I know is like we at the Ottawa Hospital, we're looking at research into AI for risk prediction, frailty scores. Perioperative preparation, interpreting scans, and like we're looking at teaching, especially as a teaching tool in addition to virtual reality and immersive reality. So all this is, I mean, what we're doing right now. But one of my main things is I'm no expert, but most of these algorithms and data sets of research has already been done, or all from the high income group countries. So I would actually would like to see more research or data sets from say from say Middle East, like say Yemen, Syria, where there's a huge humanitarian crisis, like South Sudan or wherever, like Central African Republic. I would like to see data sets or AI being used there to see how AI can actually contribute
Mhm.
to the problem at hand, rather than or most of the algorithms or data sets which come from from North American or European spheres. So that's something which I would really like to look. I'm no expert in AI. I really had. I wish I had my friend answer these questions,
Well,
but this is what I personally feel.
you can now use AI to become an expert in AI. But I think
Yeah,
I think your point is so important because I I think we're at this really pivotal intersection with AI, and the space is expanding so rapidly that if we don't advocate for this equity that we're all talking about, making sure the data sets are actually in the context of the community that you're trying to serve, and not taking a data set from the United States and trying to paste it into Cameroon for research or clinical care or otherwise. Like, it really has to be context specific and cognizant.
but there's also the question of sovereignty. Who owns the data? I mean, like I can get the technology from the US and make do it in South Sudan, but again, there's also this question about sovereignty and who owns the data, who owns the output.
Yeah.
If all the tools are like, we extract data from low resource settings,
Yeah.
and without reinvesting in the local health systems. I mean, the promise seems to be very real, but if equity is not maintained here, I guess. It becomes a lost cause.
Yeah, I mean, I think I was actually thinking that these AI tools using local data would be built by the people there. Like, I think,
Yeah,
I mean, I think that AI has the potential to either worsen the digital divide that already exists between communities, countries, however we want to talk about the language again, but it also could be a really powerful opportunity if we can build tools in communities by communities using the data of that community. It might empower that healthcare system to overcome traditional challenges, right? So if you need a specific tool, for example, in a rural community in Canada or in a rural hospital in Cameroon, it should really be built for that context and that culture and that data set. So I feel kind of optimistic that it can really help us accelerate, much like you guys mentioned in research. But I also am seeing benefit of AI in medical education and training. Um, Also have seen it at the bedside. So if we can release some of that cognitive and administrative load of our clinicians and allow them to actually take care of patients and have real-time point of care access to evidence-informed decision making, like, that's a game changer for our patients.
absolutely, absolutely.
Yeah, yeah,
Absolutely. Yeah.
yeah. Okay. We have 3 minutes left. I could talk to you all day. I want to do two things. One, I want to ask the audience if they have enjoyed this webinar. This is kind of the first one we've done in this series. It's a non-funded series. It's just friends getting together talking about global health stuff. But if people like it, I might, I don't know, invite you guys back, invite some more friends and have more discussions about global health. I've really enjoyed this in particular because we've kind of gotten into a little bit of the nuance that doesn't necessarily come out in some of the articles that we write. But I want to ask both of you in closing, with our 2 minutes left, to give me one thing that makes you hopeful. And well, let's start with the bad. One thing that gives you the greatest concern in the world or global health currently, and then one thing that makes you really, really hopeful. So, Dr. Holgar, maybe we'll start with you.
What really concerns me is the growing nationalist movement. I mean, people who are shifting away from globalization and partnerships and leaving international bodies that have, I mean, upheld global health equity for years and decades. I think they're just reversing all the gains that the world has achieved over these years. Um, However, I'm very hopeful because I mean, clinicians like yourself, Dr. West, I mean, and other colleagues, I mean, they're not giving up despite all this changing landscape in global politics. I mean, you're still engaging with peers and colleagues from around the world and mentoring the next generation of practitioners, which is something that I'm very, very, very grateful for. And I'm hopeful that, I mean, the next generation can emulate on your footsteps and also train the next generation of practitioners, global health, anesthesia, or, I mean, in all the disciplines of medicine. I really think creativity under constraint is a skill, and I have no doubt that, I mean, Anna, you've always led the way. We admire you so much for your leadership. You're a true leader. And having you, knowing you, I mean, I'm very hopeful for the future. I'm very positive.
Thank you, Holgar. That's very generous.
Well,
Okay,
I wouldn't take much time to two things. The current, I'm very concerned about the geopolitical instability, what's happening in North America, like I know, and the funding volatility. But I'm very happy about the fact that we have a shared humanity that we share, and like people like Anna and Holger, and I'm very happy to see that the fire is still alive, and as long as we have that fire still alive, we are the right path.
yeah, yeah. I can't think of anything more to say. It is a challenging time. It feels awkward to be in the United States, which has really driven a lot of these changes. Um, I don't think it's going to go back to the way it was, and so with that, I really want to find inspiration to evolve and figure out ways to continue to collaborate with you, of course, and all of our global health friends. I don't know if it's leadership, Polgar, but I'm an extrovert and I love people and I love having friends all over the world, including the two of you. And I'm so, so grateful for you for sharing time with me to have this really great conversation. And I think the word I'm going to take away from this is nuance. We were able to really kind of get into really common topics in global health, but take them out and spin them around and think a little bit more about them. So I'm really grateful to the two of you for that. Any final words?
Thank you so much, Anna. It was a fantastic topic. Thank you so much.
Yeah, my pleasure.
Yeah, I want to thank our audience for tuning in. Thank you. And Anna, please let's do this again. I think
Okay,
we're
I know.
close to
I mean, I
that.
had so much fun. I think we will do this again. So,
Thank you.
thank you so much. I really appreciate
Thank
you
you.
both. Bye, everyone.